So before I start, I just want to give a quick thank you to Vishni, Gabe, and Hamid for helping put together this webinar, and also to the listeners in audience taking time out of your day to attend this presentation. I will just go ahead and just introduce myself. My name is Goki Sule. I go by Goki as my nickname. My nationality is Nigerian. I'm a pharmacist by training and soon to become a reviewer with the FDA. So today we're presenting a loading dose of pharmacometrics. So it's an educational session brought to you by representative of the ISoP community. So this is an initiative to administer like ISoP educational community and designed to provide insight and foundational knowledge in pharmacometrics to help both new learners as well as experienced professionals expand their understanding of the field. So we hope this session is engaging and informative for you. So before we dive into the presentation, I would just like to get a sense of where everyone stands with pharmacometrics and ISoP. So Vishnu, if you can please provide the link in the chat. So please everyone just like click on that link to basically get a rate of your agreement with the statements that's listed. Basically different questions are provided in that poll. So we know where you stand with your understanding of pharmacometrics and ISoP. So I'll just provide a few minutes for that to happen. And if there's any issues, please mention that in the chat or say something. Okay, so I'm just gonna go ahead and start with the agenda for today. So we're gonna start with the overview of pharmacometrics, which includes a case study on atezolizumab pediatrics dosing. We will cover PMX career path or pharmacometrics career path, and we're gonna have conversations with the pharmacometricians on the call, and later on discuss more of the available resource provided by ISoP and conferences, and then we're gonna wrap up the presentation with a Q&A session. So what exactly is pharmacometrics or PMX? So it's more of an interdisciplinary field that combines both mathematics and statistics as well as biology to better understand and guide patient treatments. So it's specifically focused on quantifying the relationship between a drug pharmacology and how it interacts with biological targets and patient physiology to inform dose strategies and optimize therapeutic outcomes. So PMX includes several key modeling approaches. So one of them would be the population pharmacokinetics, also known as POP-PK. So this approach studies pharmacokinetics on a population level. So it involves analyzing data from various individuals in a population to understand how the drug behaves in people, often using nonlinear mixed effects model to capture the variability across different individuals. We also have the physiological-based pharmacokinetics model, also known as PBPK, which is one of the case studies I'll be going over today, which is a mechanistic model approach that builds models based off of the anatomy and physiology of the human body by integrating blood flow, tissue composition, organ-specific parameters, as well as drug-specific component as well too. So the PBK model aims to predict drug concentration in specific tissues, which particularly are useful in complex dosing scenarios and specific populations such as pediatrics. And then we also have the quantitative system pharmacology, also known as QSP. QSP takes a broader systemic level approach to things by integrating pharmacology with physiological pathways. It connects the drug exposure to biological process and biomarkers to predict the clinical outcomes. So QSP is often used to explore like drug mechanism interaction with disease biology, providing insight that guides the drug development and therapeutic strategy. So together, all these pharmacometrics approaches allows for a quantitative understanding of how that helps tailor treatment to individual patients' need, improve drug development processes, and predict clinical outcome with higher precisions. Even though there are several modeling approaches, so I think it depends on the questions you're trying to answer with the model. So you don't necessarily have to have a very complex model. You could keep it extremely simplistic. So here is 3 of the pharmacokinetics analysis arranged by complexity. So you could start off with just doing, your typical non-compartmental analysis, also known as NCA. So which is the least complex method. It's purely descriptive and serve as a starting point in PK analysis. So the non-compartmental analysis doesn't assume any compartmental structure within the body. Instead, it focuses more on calculating the parameters such as, the half-life of the drug, the clearance, as well as the volume of distribution from, concentration time point data. So, you could get more advanced into that by going further more into the compartmental analysis. So this is introducing more complexity in your model building by assuming the body can be represented with compartments. Typically, a one compartment to compartment model that captures the drug is as well as the distribution and elimination. So this approach allows us to model rate constant and use the system for simulation as well as prediction. So providing more flexibility than, the typical NC analysis and can accommodate for more detailed analysis. And then finally, you could have your more advanced type models, so which are more complex and, and very feasible for the type of analysis you're trying to conduct. So this could include your physiological pharmacokinetics model, also known as PBPK, or, the QSP model I just mentioned earlier. So this model incorporates detailed biological and physiological parameters. So to help understand, the blood flow and the tissue composition of the drugs to capture, the drug's journey throughout the entire body in a more mechanistic manner. So while the data and time provides, more information about how much of the drug is exposed in the body. So this approach will give you a better understanding of where exactly, is drug distributing to at a specific time. So this is more of the higher level complexity of model. So each level of model has its different specificity, but depending on the type of question you're trying to answer, you could best suit the model to help answer your questions. So now we're going to dive into the case study. So the case study we're going to be going over for today's presentation is just one. So it's the atezolizumab pediatrics PBPK model. So this is a work that's already been published. There's also a POP-PK model already done for this molecule already. So as I mentioned earlier, there's hierarchy in the type submodel that you're building. So as I mentioned, they've already looked at the POP-PK model. Now there is a PBPK model to have a better understanding of the molecule. So as we may know, the study of pediatric pharmacology presents significant challenges due to ethical, physiological, as well as operational factors. In traditional pharmacokinetic study or PK sampling, it's very invasive, when you're collecting multiple drug samples from pediatrics at specific, time intervals, which can be very difficult, especially due to, the infant size as well as their blood capacity. So one approach to addressing this limitation is the use of a PBPK model. So many reviews and many papers have successfully used PBPK model in characterizing the PK of multiple drugs in pediatrics population. So the figure you're looking at to the right is an example of where pediatrics PBPK model for 10 Bayer small molecules were applied to support clinical decision processes for their predictive power in different age groups. So what we're looking at here is the ratio of the PBPK predicted to the observed PK parameters for different drugs in different pediatric age groups. So the black dashed line indicates the 0, 1, and 2-fold prediction interval. Basically, 1 representing high correlation between the predicted and the observed parameter, while the red dashed line indicate the 0.8 and the 1.25, which is the bioequivalence range represent. So by looking at the figure, you can see that majority of the PK estimate ratio falls within the 2-fold prediction error range, and about 67% kind of fell within the bioequivalence range. So from this study, we can see that the PBK model shows, success in adequately characterizing the exposure of the molecule in different pediatric age groups. So this shows the applicability of the PBPK model in guiding dose regimen in the pediatric population. However, when you think about small molecules, you can't really, have the same you can't really have the same extrapolation to large molecules, because for large molecules, the processes that governs large molecules slightly differ from the processes that govern small molecule. So as a result to this, we haven't really seen more PBPK for pediatrics in being developed. So there's less confidence in using PBPK models for quantifying or explaining the exposure of large molecules when we compare it to small molecules. So here is just a table comparing the pharmacokinetics of small molecule drugs and monoclonal antibody as shown in the table. So monoclonal antibody and small molecules drug exhibit different drug behavior in the body due to the monoclonal antibody's weight. So they have limited tissue distribution and prolonged half-life up to weeks, providing a sustained therapy. So in contrast to small molecules, we don't necessarily see that, because small molecules have a higher distribution and a shorter half-life, requiring a more frequent dosing. So understanding the differences in the pharmacokinetics of the two molecules is essential, especially for development and optimization of drug therapies. So here is just, the physiological processes of monoclonal antibody in the body, which is, like I mentioned, is different from the processes that govern the disposition of small molecule. So once in the bloodstream, the vasculature system carries the monoclonal antibody throughout the body. So due to their large size and hydrophilic nature, the monoclonal antibody cannot easily, diffuse across the lipid bilayer. So diffusion is one of the mechanisms of the drug kind of, distributing all over the body, but they also use other non-specific mechanism as well too, which is the convection and the transcytosis mechanism. So as the hydrostatic pressure is pushing the monoclonal antibody in the vasculature system, so within the capillaries, there are small and large leaky pores in the endothelial vasculature of the tissue. So the convection mechanism allows monoclonal antibody to distribute into the interstitial space of the tissue. So there's also the transcytosis, which involves the monoclonal antibody uptake fluid phase, leading to the binding within the endosome. So here is a better depiction of what happens during the uptake. So after the uptake occurs, the pH drops, of forming acidified endosomal compartment, which triggers the IgG and FcRn binding complex. So this is exactly the reason why IgG has a prolonged half-life compared to, while monoclonal antibody have a prolonged half-life compared to your typical small molecules, due to the protection from the FcRn-mediated recycling complex. So let me just use this mouse. So as you can see here, so once the acidified endosome takes place, you could have two scenarios where you could either get the protection from the FcRn binding complex, or you could also get the degradation in the endosomal space. So if it's protected by the FcRn binding, it's basically recycled back into the systemic circulation, providing a sustained exposure to the drug. So moving forward is the atezolizumab, which is a IgG1 monoclonal antibody that targets the PD-L1, which is used to treat various cancers. So atezo works by blocking the interaction between PD-L1 and PD-1, which are proteins that cancer cells use to evade the immune system. So in this case study, a PBK model was developed for atezo to predict exposure in children, supporting dose recommendation for pediatrics patient age 2 to 18 receiving 15 milligrams per kilograms of atezolizumab, which is comparable to the adult dose of 1,200 milligrams. So here is just a minimal PBPK model structure depicting the process I just mentioned earlier. So as I mentioned, once the monoclonal antibody is within the system due to the limited distribution, so they used minimum PBPK model to kind of assume that the distribution is similar across all tissues. So it's just one tissue that's being, depicted here. So within the vasculature, you have the parameters here depicting the large and small leaky pores for the convection mechanism for the monoclonal antibody to distribute into the interstitial space. And then you also have the diffusion parameter here, showcasing the drug being able to diffuse across both the vasculature and the interstitial space. And here we have the parameter explaining the uptake mechanism, the transcytosis method, where, you have the binding to the FcRn and, protection from degradation in the endosomal space. So on top of that, they also included, a competition between the endogenous IgG and atezolizumab binding for FcRn. So the reason why they included this is because when there's competition for FcRn, it's a significant caveat in the pediatric population due to the endogenous IgG at birth. So due to passive immunity, so the endogenous IgG is as high as an adult at birth. So it starts to decline within the first couple of months till the child starts synthesizing its own. So as you can see, this will be a potential caveat when extrapolating from adults to pediatrics due to this age-related dependency. So by incorporating this, we can see that there's a non-linear relationship, which can be difficult for your typical alimentary scaling. So as the endogenous IgG changes, there is competition for monoclonal antibody, which may lead to, changes in the monoclonal antibody exposure, specifically in the younger age group. As you can see here, from, I would say from like 3 months all the way to 1 month or 1 year old, you can see that's when the child starts synthesizing its own. And then from birth, it's kind of like a sharp decline from there. So here is just, observe and simulated plasma concentration from the model for a 15 milligrams per kilograms IV dose of atezolizumab dosed every 3 weeks in pediatric patients. So from the model, they were able to, do simulation to capture the clinical data. So what we're looking at here is the panel that showcase subjects with different ages ranging from 2 years old to 16 years old. So the red circle represents the observed data or the clinical data collected from the study. And then the green lines are pretty much the simulations from the PBPK model. And then the shaded line, I know it's really hard to see from this image, but there's a shaded green area, which is the 5th to 95th percentile of the simulation. So by looking at this plot, we can see that the PBPK model is able to accurately capture the exposure of atezolizumab in various age groups. And by this, they were able to verify the model to be able to characterize the exposure of atezolizumab and then run further simulations to, guide dosing with this molecule. So by incorporating the IgG concentration changes and competition for FcRn binding, the model was able to capture the exposure of atezolizumab in younger patients. So the model showcased that the IgG level and competition for FcRn binding enhances the atezolizumab recycling efficiency, which could lead to lower catabolism due to the protection and higher exposure in pediatric age group. So additionally, with the model, you were able to see that the 15 mg per kg dosing of atezolizumab provides exposure similar or comparable to the 1,200 milligrams dose in adults. So this is used to support the use of the 15 milligrams per kilogram dosing regimen to ensure an adequate and effective atezolizumab exposure in the pediatric patients, specifically within the ages of 2 to 18. So that is just, an example of how, pharmacometrics can be used in the drug developmental space. So pharmacometricians have a range of career options across different sectors, as well as opportunity to specialize in various aspects of the field. So pharmacometricians can work in regulatory agencies such as the FDA here in the United States, where they review drug application and contribute to drug guidelines development. And then you also have, CROs where pharmacometrician can conduct analysis to support drug development and for multiple clients. We also have the pharmaceutical industry, which focuses on in-house drug development, utilizing pharmacometrics throughout the entire process. And then we also have academia, where pharmacometricians could engage in intensive research, which advances the science of modeling and simulations. So with all these sectors, there are several specialized pathways. So you could go more directly into your traditional pharmacometrics, which is the PKPD, which involves modeling population characteristics and predicting drug exposure and responses, which helps with guiding dose selections. We also have the quantitative system pharmacology. This area focuses more on the mechanistic interaction between drug and the biological systems, as I mentioned earlier, aiding in the biomarker identification and study design. And similarly, with the case study I just explained earlier, with the PBPK, you're able to model the drug behavior based on the physiological parameters and then scale that model to specific populations, such as pediatrics, which is crucial for understanding drug-drug interaction, and also for special populations such as pediatrics, as well as geriatric dosing. So the diversity in both sectors and specialty for pharmaconutrition can be tailored to the career to fit the interest of the person. So from regulatory work all the way to detailed pharmacological process modeling. So pharmacometricians are vital parts of drug developmental teams. So working alongside a diverse group of specialties to design and develop medicine for patients. So pharmacometricians can work closely with biologists and as well as preclinical scientists to understand the biology and pharmacological basis of the drug. They can also collaborate with statisticians to ensure that the data analysis supports the model of the behavior of the drug accurately, as well as work alongside biomarkers experts contributing to data and pharmacometrician used to develop predictive model of efficacy and safety, helping to inform decision and dosage and treatment of schedules. So similarly, you can also work with clinicians as well as safety scientists, which rely heavily on the pharmacometrician insights to optimize clinical trial design and enhance patient safety, and also address any potential, adverse effects that might arise from the molecule. So together, clinical pharmacologists and pharmacometrician bring the quantitative insights to developmental processes using the expertise to predict how the drug would behave in different populations. So this is essential to ensure that new treatments are both safe and effective for patients. So now I'm just going to switch where we have the other speakers come online to share their experiences with pharmacometrics. If the other speakers want to turn on their camera to introduce themselves, we could start off by, mentioning your nationalities, your training background, as well as your current occupation. And I guess I could go first then. So as I mentioned earlier, my name is Goki. I'm Nigerian. I'm a pharmacist by training, and I'm currently in the process of transitioning from a postdoctoral fellow with UNC and Genentech to more of a reviewer with the FDA. So my experiences with pharmacometrics actually started about 3 years ago. So I've been in this field, learning different modular tools and techniques from power PK analysis all the way to PBPK modeling. And each step of the way, there's always something interesting and something to expand upon, and how we can use this to optimize drug dosing in different population. So these experiences have made me have a better value for understanding the drug processes and how to optimize dosing in patients. Stop sharing for a second.
I can go next. So hi everyone, my name is Fernando Carreño. I'm from Brazil. I'm a pharmacist by training, and I started my career working in the preclinical space. I was working studying drug candidates and the PK in animals, mainly in rats and in mice. And then I did that during my undergrad, and then when I started my master's, I did my master's and my PhD in Brazil as well. I was also working in the preclinical space, but then developing drug nanocapsules or drug delivery systems, and trying to understand that how the drug delivery systems modulates or changes the delivery of the drug to the brain. And here's where I transition a little bit from the animal experiments only to applying pharmacometrics and really trying to build models that allows us to describe the process of drug delivery to the brain in animals. After I finished my PhD, I got an opportunity to do a postdoctoral fellowship with University of North Carolina in Chapel Hill and GSK. And that's where I transitioned my career from the preclinical space to work more with clinical data. When I was in Chapel Hill, I worked with pediatric um, clinical trials and applying pharmacometrics to support dosing or understanding better dosing, for example, for children with obesity. In the second year, when I transitioned from UNC to GSK, because the fellowship is a year in the academia and the second year is in the industry, I then start working in the drug development and applying modeling and simulation tools to support, for example, dose selection from a phase 3 study. After I finished the fellowship, I was hired, and now I work as a clinical pharmacologist in the modeling and simulation, in the clinical pharmacology modeling and simulation department in the oncology, supporting using pharmacometrics tools, the development of different oncology assets here at GSK.
Hi, everyone. My name is Patrick Hannafin. I am from the United States. I've been a pharmacometrician, or been in the field of pharmacometrics for about 10 years between industry and academia. My background is originally in engineering, so the concept of pharmacy and drugs were very new to me when I first joined this field, but quickly gained a lot of excitement on the applications of math to really explore and describe drugs and both pharmacokinetics and pharmacodynamics. I have a little bit of background or most of my academic background in infectious disease, working with multi-drug resistant gram-negative bacteria and individualizing dosing for patients with critically ill patients with hard to treat infections. From there, I've also transitioned more into an oncology role, using pharmacometrics, or what we call model-informed drug development, to inform study design, drug development of oncology compounds across different modalities, from ADCs to monoclonal antibodies to small molecules, to really help understand how these drugs can be used safely and efficaciously to treat patients of different kinds of cancer types.
Hi everyone, I'm Ramya Mahadevan. I'm a PharmD graduate from India and I'm currently a postdoctoral research associate at University of Southern California. My pharmacometrics training started 3 years ago, where I started as a pharmacometrics fellow at Pumas AI, where I was mostly doing a meta-analysis of the previously published population PK model to identify a generalizable model that lead to the precision dosing that can be used in the hospital settings. And currently, I'm working mostly in the mechanism-based PK/PD models for antibiotic combinations to identify the synergistic effects of the antibiotic combinations that to treat the multi-drug resistant gram-negative bacteria. Thank you.
Yes, thank you guys all for sharing your experiences. If there's any questions right now from the audience, we were happy to take any questions before we transition to the next phase of the presentation. Okay, I don't think I see any questions. In that case, I'll hand the
There's,
presentations.
I see there's
Oh.
a hand up.
yeah.
Oh, okay. Yeah, I'm not sure how this works. Okay.
Thanks, Goke. I see I've been unmuted. I do have a couple of questions, but I'm not quite sure whether we are there yet. My questions may yet be answered, but they have to do. And if they can't be answered by this panel, then that's fine. My question relate to look, this is a topic that has been in discussion for a couple of years. I remember going to Japan, and this was a topic, especially in pediatric medicines, the development in terms of protecting a vulnerable group from unnecessary research. But the key message was that children are not young adults, so they have to be studied. So somehow they need to be studied. So modeling seems like a good idea. But obviously, these models need to be validated and to be evaluated
Yes.
at the same time. So how are they validated and how are they evaluated so that we can rely on the outputs that they give us that would then inform our clinical decisions as far as dosing and dose maintenance is concerned? Thanks, Goke. If there's not the panel, then that's fine. I'll listen into the next panelists. Thanks.
Yeah. So as I was mentioning during the case presentation, especially once the model was developed. So yes, you would need, especially for PBPK specifically, to help verify that model, you would need some sort of data to assess that with. I know again, I don't really have much experiences with doing more allometric scaling from preclinical studies. So that's another way too, to also potentially validate the model to see how well the model is able to predict the exposures. But from the case presentation I just showed earlier, those are clinical data collected from different individuals, not just, from one specific age groups. So from there, they were able to run simulations to see how well the model was able to characterize those data. And from there, you could help validate the model and then extrapolate that to potentially other molecules. So I know I only mentioned Atezo during this case study. So another work that I did when I was at Genentech is on bevacizumab, where we took that same model and extrapolated to bevacizumab to see if the model is able to characterize the exposure of bevacizumab. So with bevacizumab, we have, more pediatrics data in that molecule, and we were able to, use the model to help capture the exposure of bevacizumab, and potentially, other studies that's being done using similar models, using different data to help, have confidence in using our models to, make those predictions. And then from there, you could, use those models to answer specific questions you're trying to answer. I hope that answers your question. And I opened the question to the other panelists as well, if they want to provide their insight.
I can share a little bit of my experience on that area as well. So when I was in Chapel Hill, we worked a lot with pediatric drug development, and then in this case, for example, children's with obesity. And then there is two ways that we could validate or develop models and then validate the models. One was by building virtual populations, so using information from databases, we could create those virtual populations of children with obesity that kind of mimics the physiology or the alterations that you're going to observe in different age groups of children with obesity. And then you can use that to run simulations. And then if you are, for example, proposing some dose changing or modifying the drug dosing for a drug that is already in the market, but is going to be used for this pediatric population with obesity, for example, you can use real world data or data that, or PK data that is collected as per standard of care. And then you can use that data to validate your model. They are not rich data, they're normally sparse data, but at least you can use that information to really validate the model and gain confidence that your model is really supporting the hypothesis that you're making, or the proposal of drug change or dosing changing that you are making as well. So that is an alternative way as well, using real world data to support your model, or to validate somehow your model.
I'm happy. I'll keep on listening. Thanks. Okay.
Okay. If there's no other further question, I will hand the presentation over to Fernando to go over more information about ISoP.
Thank you, Goki. If you don't mind sharing the slides, I'm having some trouble with the PowerPoint.
Okay. I would do that.
Yeah, so as we've been discussing and as Goki presented, and as you can see, there is many ways for us as pharmacometricians to work in this field. And there is many resources that are available to start the career in the pharmacometrics environment. I don't know if you can click again. I think there is some animation. Okay, that's fine. So there is many resources that are available to start the career in pharmacometrics. So for example, we have some books that are available, and we can gain information. There is some webinars that we can attend. There is a list of different resources that we can use, and there is the ISoP, and that's why we are here also to discuss and present the ISoP and the resources that the ISoP has. So what I'm going to do, I'm going to share my screen now, and I'm going to share the ISoP webpage and show a little bit what we have there, and then we can return to the slides. So let me just are you guys able to see the ISoP webpage?
Yes.
Okay. Yeah, so actually let me do one thing. I just want to use the home. Yeah, so here is, let me do one thing. Sorry. I want you guys to see the initial ISoP webpage when you join without being logged in. It's still going to my member homepage. Okay. Sorry guys, I'm trying to do a live demo, but it's not okay. Yeah, so when we join the ISoP webpage, this is what we see. So this is the International Society of Pharmacometrics webpage. If you search on Google ISoP, you can also find the International Society of Pharmacovigilance. So yeah, just making sure that you are in the right webpage, you are on the International Society of Pharmacometrics. And this is kind of the web page that ISoP put together, and that contains a lot of learning resources and information about pharmacometrics, and that allows us to really develop ourselves and be part of this big community. So when you join here, you can see that there is some information. There is some information regarding how you build your network, how you can develop professionally, and how you can contribute to science by being part of ISoP. There is some information about ISoP, the history, the governance, the leadership, and all of the other informations. There are information about conferences, and there is the Learning Center, which I want to highlight. So in the Learning Center for the ISoP web page, we have live webinars, we have on-demand webinars. So there is webinars that are going to be live, and then they're going to become on-demand webinars. There are a series of modeling informed drug development webinars, as well as some shiny lecture series. All of that are resources that we can use to develop in the field of pharmacometrics. So for example, here we can see some upcoming live webinars. So we have a upcoming webinar about long-lasting injectables. We had another webinar on how to prepare for a successful MIDD, so modeling informed drug development meeting with FDA. And then there's some webinars that are going to be recommended for you based on what you inform when you join ISoP. So all of this information you can access by logging in. And then now I'm going to switch to the web page as a member, so you guys can see. So I'm a member of ISoP, and you can see here that then I have access to, like, here it's my members web page. There is some information about myself here, and then I have access to some special information. So in the Learning Center here, I will have access to the different webinars, the different MIDD series, and all of that information. There is also another thing that I want to show here. Okay, can you return to the slides? I'm gonna use the slides now to, because I think it will be if we can move. Yeah, sorry. Yeah, if you can return one. So this is what I just mentioned about the webinars and in additional resources that ISoP offers for you as a member. If you can move one slide. There's another training resource library. This library contains a lot of curated trainee resources that are recommended by the ISoP members. So this group here, and I just want to give a shout out to Goki and Ramya. They were able to curate all these trainee resources and classify this as, for example, here we can see as a beginner or advanced. And then there is a lot of information that you guys can use to really train and develop yourselves in the field of pharmacometrics. If you can go one slide. ISoP also offers some additional resources. So there's some discussion forums. There is some ACOP tutorials and in the YouTube channel as well that you can find some videos online. This is not only for members, but some of the webinars or some of the information is going to be only for members. Next slide, please. There's also some special interest groups that you can join that will have the knowledge, learning, and technology in different areas, for example. So members from academia or industry, they cooperate to produce some solutions for particular fields. So for example, we have some special interest groups in clinical pharmacometrics, in computational science, in QSP, in statistics and pharmacometrics. So, and you can also, as a member, you can join, for example, the education committee, as we are here representing today, and be part of this type of webinars where you can help us to reach and spread the ISoP knowledge or information. So not only you can not only join specific interest groups, but you can also join some of the other groups, for example, the educational committee, if you can move. Also, ISoP is partnered with some other communities. For example, PMX Africa is also a partner with ISoP. ISoP also organizes the American Conference of Pharmacometrics, the ACOP, which is a conference that is happening now in US, which is the official scientific meeting for ISoP that not only allows us to really develop yourself as a pharmacometrician and gain knowledge and information, technical information, but also connect with people in the field and really networking. There's also some partnerships with PAGE in Europe, but also PAGE in India and also Australia. There is a community that is in South America, in Portugal and Spain, which is called Redife, that is also partnered with ISoP. And so ISoP also supports that community that are spread throughout the world. If you can. So in summary, the key benefits of being in ISoP membership is kind of highlighted in this slide here. So you can build your network, so you can connect yourself with other pharmacometricians in the field and really get resources, information. You can develop yourself professionally by really attending the webinars. You can contribute to science, so you can participate or you can join those special interest groups where there is discussions and really helping moving the field along. You can stay in the know, really learning or get information regarding pharmacometrics. You can volunteer on a committee, for example, the educational committee. So there is a lot of benefits to become an ISoP member. Goki, if you can move to the next slide, please. And then how you can become a member. So you can join the website. There is information regarding the membership fees. The membership is for a calendar year. So it starts 1st of January and ends December 31st. And then depending on the country you are, and also if you are a trainee or if you are already a professional, there are some differences in terms of the membership fees, which is highlighted here in this slide, but you can also check the ISoP website and become a member. If you can move to the. Yeah, so in summary, this is kind of ISoP in a nutshell. Really, I highly recommend you guys to go to the website and to check the information, to read more about ISoP and what resources and knowledge ISoP can really provide. We have a link in the chat, if you guys can please share, which is a a poll before we are closing this session. We are sharing a poll for you guys to answer as we did at the beginning as well. And if you can move to the next slide. We are open now for questions regarding ISoP, questions regarding pharmacometrics field. I will also ask our colleagues to come on camera as well, and we can have a discussion about the resources ISoP have, membership, other information, the volunteer options.
Yeah, so I did see a few questions in the chat. Just go through them right now. So someone asks, thank you, presenter. I look for the Berkeley software for pharmacometrics modeling. Actually, I haven't really used, I'm assuming that's the Berkeley Moderna software. I'm not sure what the question is. And then I see another one regarding external and internal model validation. Is that pertaining to the case presentation or just in general? But again, I might be reading this question slightly late because I wasn't looking at the chat during the presentation. But if there's any further questions, please feel free to, come online and unmute yourself to ask any question you may have. Oh, someone said, how do we get the slides for your presentation?
We can make this
Yes.
available as a part of the Zoom recording that will be available after this call is finished.
Thank you, Gabe. It seems there are no questions. If not, then we could just wrap up this presentation. If there are no further questions for us. Okay. Well, I would like to thank everyone again for attending. Oh, 1 second, I just saw a question pop up. Oh, so sorry, I was looking at the wrong chat earlier. Okay, I'm seeing more questions now. Sorry about that. Okay, the first question is Pharmacometrics Africa online course. Will this be in a person course ever? Okay. Vishnu, I'm not sure if you're able to answer that. I'm not familiar about the Pharmacometrics course.
Sure,
Pharmacometrics
thanks.
Africa course.
Thanks, Goki. So I think so Pharmacometrics Africa itself runs loads of courses, and that is just in partnership with different academic institutions as well. So it really depends on which course Ingrid is referring to. And maybe, Ingrid, it would be good to watch the pharmacometricsafrica.org website and watch the space, because any courses that come up are advertised there and then circulated to the various chapters as well. And this changes. So for instance, we just ran a PBPK workshop earlier this year, but there are some standard self-paced courses that would just continue online, but any other courses is add-on. Thanks, Gabe. I see Gabe has put full course listings as well. You're also welcome to reach out to me if you're looking for something specific, and then I could direct you better just off this call.
Thank you, Vishnu. The next question is, can you talk if any update about NLME for POPIC analysis for regulatory perspective? I can't really speak onto that yet because I haven't really started too much into the regulatory processes. If any of the other speakers have experiences or any knowledge on any updates on that.
Unfortunately, I don't have experience with NLME?
Yeah, I'm not sure if the context of the question is about updates to NLME software specifically or NLME techniques. I mean, if there's a specific kind of software question, then maybe that's best directed to the makers of said software. This is a tight-knit community, so a lot of them are relatively easy to reach once you get in contact with them.
Hey, alrighty. It seems like there are no further questions in the chat, or I don't see any hands raised or anything. So again, I would just like to thank, the speakers as well as the audience for, taking time out of their day to, listen to this presentation. And hopefully, you got more information about pharmacometrics as well as ISoP, and hopefully, could potentially become a member in the future to gain more resources and, become, more involved within this field. It's a very nice community. Everyone's willing to share the knowledge and, expand, their experiences with you. So if you have any questions, please feel free to reach out to me via email or LinkedIn. I'm happy to take on other questions outside of this. Yeah, if any other speakers don't have any closing remarks, you could say so now.
I'm just seeing a little bit more about NLME, about question about techniques. And I think if there are questions about techniques, you could look into the tutorials for the ISoP webpage, as there tends to be a lot of resources there on the ISoP webpage on specific NLME techniques that can be used, and to learn more about when to appropriately use them.
Yeah, and I just saw one question I missed by Ingrid. I'm so sorry. I've been trying my best to keep in track of all this question. Says she asked me, the question is, are there any medicine development grad diplomas that can be recommended? In terms of diplomas, I'm not too sure. Are you meaning more of like a postdoctoral fellowship? I know there is a few here in the United States, but I can't really speak for other countries. Me and Ramir, actually Ramir was the one you did here in the United States, but I know right now you're a postdoc with with USC, but I'm not sure if you could speak on other countries' postdoctoral fellowship approaches as well.
Not sure about other countries, about the postdoctoral programs.
Okay.
Roman, maybe you can speak a little bit about the postdoctoral program that you were involved with within the United States.
Oh yeah, after my PharmD degree, I'm doing a postdoctoral research associate in pharmacometrics field. That program, it is completely an academic program. It's 2 years, and there is a possibility of an extension. And there are other postdoctoral fellowships which is connected to the industries, where 1 year you do the fellowship in the academics area, and the next year you do it in the industry area, and that is mostly related to the pharmacometrics field. And there are other programs like regulatory affairs, postdoctoral programs in the United States too.
Thank you for that, Ramir. And also, as I mentioned earlier, I also did a postdoctoral program as well too after my PharmD degree. So mine was in combination with the University of North Carolina Engineering Tech, which is a 2-year fellowship that splits between academia and industry. So the first year was mostly doing research in an academic setting, and then the following year, working in the industry space, specifically Genentech. And now I'm transitioning to the next phase of my career. I'm seeing more questions pop up because there's the Q&A chat, and then there's just the webinar chart. So I'm seeing questions on both. So on the Q&A chat, someone said a phase 1, phase 2 trial used healthy males volunteer to determine a dose combination, metformin and DTG. Another study used a phase 3, 4 obese women to determine metformin's DTG drug interaction. how best to compare the two study results, exposure to metformin difference.
I don't think the purpose of this webinar is to be more of a consultancy. So I think we'll probably withhold, discussing advice on how to do some sort of analyses. But again, there is many individuals you can reach out to within the ISoP Education Committee or the ISoP in general to get advice on your questions. Of course, there are going to be study differences that should be considered. And I think, a question is the answer to that question would be a lot more nuanced than what we can provide at this time, or anyone can provide at this time. But maybe we'll withhold any sort of consultancy related questions.
I think I saw someone raise their hand. I'm not too sure. But okay. Oh, actually, let's see. You can unmute your mic, on Maya. Maybe this was a long time ago. Apologies on this. I'm not so familiar with this processes of Zoom, but you could go ahead and ask your question if you have any. I'm just looking in the chat one more time, but okay, thank you all again. Okay, but thank you all again for joining. We'll just now wrap up the presentation. Enjoy the rest of your day and, reach out if there's any further questions offline.
Thanks, everyone. Bye-bye.
Thank you.
Thank you.